Professor Busi is the first NIHR research professor at the University of Manchester and a professor of clinical psychology. She is an honorary consultant clinical psychologist at Greater Manchester Mental Health Consultation Health NHS Foundation Trust. Also co-director of the Complex Trauma and Resilience Research Unit and editor-in-chief of the British Psychological Society Journal Psychology and Psychotherapy Theory Research and Practice. She completed her clinical training at the University of Newcastle, Australia, and worked as a clinical psychologist at an early intervention service for a number of years before moving to the UK and take up a clinical academic post. She led a large program of research focused on developing digital solutions for people with severe mental health problems and managed a portfolio of research from all the major funders, including the Wellcome Trust, the National Institute for Health and Care Research, and the Medical Research Council. Now, she today is going to present to us how to move from the real world to the digital mental health. She will present to us from signal to system, building digital care pathway for severe mental illness. Without further delay, I pass the time to Professor Gusi. Professor Gusi, please.
Thank you. Okay, thank you for that introduction. Hello, everyone. I'm really pleased to be here today. Thank you for the invitation to speak at the conference. So my talk today is titled From Signals to Systems, Building Digital Care Pathways for Severe Mental Illness. And I want to focus on how we build digital markers and digital signals into clinical systems, rather than only thinking about how we develop more apps or better algorithms, is how they connect up with clinical systems. And my work focuses on psychosis or schizophrenia. So I work primarily with people with severe mental illness. And often I hear people say, well, you can't really do digital mental health with people who have serious mental health problems. But I hope you will come to see that that is not the case, that it is very much possible. So just these are my declaration of interest. Okay, so my talk's going to focus on digital measurement and what's called measurement-based care, primarily using digital data that's generated from methods that you might understand to be experience sampling method or ESM or EMA or active symptom monitoring, as well as sensor-based data that's collected either from sensors in the smartphone or wearable devices. And I essentially have 3 take-home messages from my talk. So if you remember anything from going away from the talk, it's these 3 things. Digital signals aren't really in and of themselves clinical insight until they're interpreted. So data that's collected digitally is only the starting point. And often we focus a lot on how do we technically do all of this work. But digital markers really need context and governance and human judgment before they can become meaningful in care, okay? The second message is that because I'm talking about digital markers, identifying these markers to predict when somebody might become unwell has limited value unless it results in a change in care. And so an algorithm may detect risk, but if it doesn't lead to a timely and appropriate clinical action, then it hasn't improved outcomes. And so the system around the digital tool or the digital marker matters just as much as the digital marker or the digital tool itself. That's my second message. The third message is that digital mental health is a care pathway intervention. It's not just a technology intervention. So we're not just building the tech or the apps. We want to ideally for this to have impact for patients and for clients building a care pathway. And it's these 3 ideas that are what frame my talk today. So if we look back over how the digital mental health field has developed, I think it's evolved through 3 broad phases. So in phase one, I think what we did was ask whether meaningful data could be captured using a digital tool. So we were looking at, could we develop apps or some kind of tools that capture things like symptoms or mood or sleep or heart rate, or phone use and social rhythms. And that wasn't a trivial question, particularly in the area of psychosis where I work. Because motivation or instability or privacy concerns or mistrust may all shape engagement with the tech. So we first had to show that it was possible and feasible and safe and clinically meaningful to collect data digitally. And we now know that, yes, we can do that. So we don't sort of need to prove that proof of concept anymore. And then in phase two, the field asked whether digital data streams could generate clinically useful insights or signals. So could we identify things like early warning signs of a mental health problem, relapse markers, or deterioration or changes in functioning? And this phase has brought real analytical progress, but it's also exposed heterogeneity in methods and population and outcomes. So this is a promising field, but heterogeneous at the moment. And now I think we're sort of moving into this phase three, which is systems integration, and hence the title of my talk. And at this stage, the question isn't, can we collect the data or can we detect maybe a signal of somebody becoming unwell? The harder question is, can that signal be built into a care pathway that's usable, trusted, equitable, and sustainable? And this is really important in psychosis because timing matters. So a digital signal or marker that someone's becoming unwell that arrives too late has limited clinical value. And so a signal that isn't trusted by patients or clinicians or services also won't be used, however technically impressive it may be. So the promise of digital mental health is real, but the challenge is bigger than just the technology that we're building. And it's this distinction and promise in reality is where I want to begin. So for more than a decade, digital mental health has been built around a powerful promise: earlier detection, more personalized care, and scale. And in psychosis, that promise is really compelling because timing matters. So the earlier we can detect whether somebody is becoming unwell and intervene, the better outcomes that that person is going to have. But actually, the reality of doing that is quite complicated. And just collecting more data, even collecting more data digitally, hasn't necessarily led to better care. We are increasingly good at identifying digital markers of behavioral patterns and symptom fluctuations from a research perspective. But if we want these markers to have clinical utility, they must be understood, they must be trusted by patients and by clinicians, and they must be interpreted in context and linked to some kind of response. So they can't just happen in isolation. And so if we want to really bring this value into the community and into the people we're trying to help, I think we need to look at the care model that we're trying to change. So I'm going to start with a scene that's familiar across many healthcare systems. I'm not sure what the clinics look like in Hong Kong, but about 20, 30 years ago, this is what a mental health clinic in the UK would look like. It's a generic waiting room. The clinician's office is over to the side there. It's fairly kind of run down, not particularly inviting. And the model of care is organised around episodic contact. So a patient comes in, they may have been experiencing symptoms for several weeks, sometimes several months, to see their psychiatrist perhaps. And usually the psychiatrist or clinician will start the conversation by saying, "How have you been?" And this sounds simple, but in practice, actually, this question carries an extraordinary burden because it assumes that somebody can remember how they're feeling, that they're able to communicate the patterns perhaps that may have been unfolding over the past few weeks. It assumes the person feels safe enough to disclose to somebody they may not know very well how they're feeling, and describe these changes in a very brief appointment. So you don't really get very long to see the psychiatrist. And I don't know about you, I find it difficult to remember how I was maybe feeling a few days ago, let alone a few weeks ago, especially if I had a lot of stress going on in my life. And in psychosis, answering that question can be really difficult because your experiences may have been fluctuating. Some changes may have been quite subtle at first, and you may not be aware that they were necessarily a symptom, for an example, of an emerging problem. And so the patient will tell the doctor how they've been feeling as much as they can remember. The doctor then makes a treatment decision based on that conversation, and then the patient leaves the clinic. And it goes blank. So the problem is not that nothing happens between appointments. The problem is that the system has very little visibility of those changes as they happen. And this blank space matters because something like psychosis, but also broader mental health problems, are shaped by timing. And so what's obvious later in hindsight, had you have known what was happening at the time, you could have perhaps got more effective treatment or an earlier response. And it's this episodic care where these early signals can be delayed and fragmented or missed altogether and lead to escalation in problems, in mental health problems. So let's fast forward. This is today. Imagine that's not 20, 30 years ago. We're looking today. And this image in the middle is maybe a more modern day mental health clinic in the UK. What do you notice has changed? Yeah, okay. So there's like maybe nicer chairs and a few plants around, and the light is maybe a bit brighter. There's the doctor in their consulting room now has a computer, yeah, and the medical notes are electronic, so they're not on paper anymore, they're now electronic notes. And what's changed about the underlying model of care? It's remarkably little. Nothing has really changed, okay, in all that time. And so the patient still comes in periodically and we ask, how have you been? We make treatment decisions based on a brief clinical encounter. And then once again, the person's life beyond that appointment remains invisible until we see them. So I want you to think about a real clinical example now. I'm going to introduce you to somebody called Alex, who before I knew was Alex, so I called the person Alex. Now, Alex isn't a single real person, but a composite of many people that I've worked with over many years. And I'm using this story to illustrate what this episodic model of care looks like from the patient's perspective. So just imagine Alex. Alex comes into clinic because things haven't been going well. And she tells the psychiatrist that she's been sleeping less. She feels more on edge. She's begun to think that her neighbor is watching her. And the psychiatrist listens carefully, explores her experiences, asks questions, and based on that conversation, Alex starts on a low-dose antipsychotic, and then the doctor arranges a follow-up. And then Alex leaves the appointment. So a fairly standard appointment. And it goes blank. It's 20, 30 years on, same model of care. The psychiatrist waits for the medication to take effect. The clinical team wait to see whether the plan has worked. And the clock is ticking. So in the first few weeks, Alex tries to follow the plan. She takes the medication. She hopes things will settle. Her family are really hoping this works as well. But those early days are difficult. So she feels heavy in the morning. She's maybe feeling restless at night. And after about a month, the side effects of the medication have become part of her daily life. So she's sleeping at unusual times. She's quieter with her family. She's not replying to any text messages on her phone. And so she misses a dose of medication because she just wants to feel like herself again. But then she misses another. And then the treatment that's intended to help her is making things harder for her. And her sleep starts to worsen. Her fears are becoming more fixed. And this gap between Alex and the service that are trying to help her is widening at exactly the point where Alex would need clinical review. So this is 3 months later. Alex comes back into, well, she's due back in clinic, but by now she's become more withdrawn and stopped her medication. And she feels too ashamed and maybe too suspicious to ask for help. And on the morning of her appointment, she feels like she's unable to get on the bus to come to the appointment and she doesn't attend. And soon after that, the family contacts the clinical team and we move into a crisis response. And I want to pause on this blank because this is where Alex is living with the consequences of her experiences and the treatment decision. And it's also where response to treatment might have been detected, the side effects could have been discussed, the medication review could have been supported, psychosocial interventions could have been offered, and relapse risk might have been recognised earlier. And it's precisely this blank where digital technologies may have their greatest potential, not to replace clinicians or human care, but to help us see earlier, understand more fully, and respond more efficiently. So psychosis is, I think, an especially important context for digital mental health because this issue of timing really matters. Psychosis runs a relapsing course. It often has a trajectory that's preceded by what's called early warning signs. And we're not very good at predicting when somebody may have a relapse and intervening early. Often treatment for relapse is a crisis response, so it's reactive. And one of the challenges we face is that our community mental health services are still organised around this episodic contact, okay? And so information reaches the team in snapshots, even though the person's experience is changing continuously. And for a condition like psychosis that fluctuates over time, it's shaped by stress. I've been thinking about how we use digitally generated data to better capture these fluctuations that may reflect deterioration in those blank periods so that we can create insights for a patient and get help when it's needed. And digital technology creates the possibility of moving from what we call reactive care to preventive care, okay, and proactive support. And you'll be very familiar with the benefits of digital technologies that people talk about all the time. But the key word here is possibility. Digital only becomes a transformation if the service model, okay, so the stakeholders and the people that we're working with change alongside the digital innovation. Because digital technology is a very disruptive technology when you're trying to integrate it into services. And you need to be thinking about the service and the ecosystem around the technology at the time you're building the technology. And Professor Chan showed a similar slide in her talk. So digital mental health covers a broad range of tools and they have different purposes and different evidence base and functions. And like I say, if you're starting out building a digital tool, it's important you consider how much clinical oversight is going to be needed with the tool. So are you building something that's just a standalone tool that goes on an app store that someone downloads, or are you trying to build something that's going to integrate within a system or clinical context? And that's really important because we know that most apps, you know, if a person downloads an app, especially a health app from the app store, they stop using it very quickly. So people use it for a while and then they stop very quickly. So it's really important to think about this from the outset. And these are some examples of rigorous trials of digital interventions in psychosis that have been recommended in the UK National Health Service for use in routine care while they gather real-world evidence. And what I want to highlight about these trials is that they each have a clear underpinning theoretical framework and a mechanism of action with different levels of human input required. And it's important, I think, when you're building your digital intervention or digital tool, you're really clear about what the mechanism of action is of that tool, not just adapting something that you do face-to-face into the app. Okay, because that's not really using the full benefits and of what the digital technology can offer. And I'm just to pick out two examples from this slide. There's the slow-mo study. This is the first one here for paranoia. This is a blended digital therapy that targets reasoning processes linked to paranoia and has some really strong trial evidence that it reduces paranoia among people with psychosis. And the other one is the Avatar trial. I'm not sure if you're familiar with this, but this is a blended digital therapy for people who experience distressing voices. And what happens is that the person creates, works with a therapist to create a digital representation, so an avatar of their distressing voice that they hear. And then in a three-way conversation between the therapist and the client and the avatar, the patient practices responding to the avatar in a structured way to try and reduce the perceived power and associated distress of the voice. And there's been multiple trials of this now. A large definitive trial tested 2 forms, a brief and a long version of avatar therapy, and showed that it reduces voice-related stress. So there's really promising interventions with really rigorous research trials behind them. Okay, so if we look across the trials, you'll see that the effects of digital mental health interventions sit at around a small to moderate benefit. So the number that sort of keeps popping up across the trials is an effect size of about 0.28. So that's sort of where the effects tend to sit around. But the effects are pretty heterogeneous and depend on who the intervention is for, what it targets, and the level of human involvement and the outcomes that are measured, so that you get some variability. But benefits seem to be stronger when the intervention has a specific clinical target and when the outcomes match the proposed mechanism of action, which is why it's really important to identify that mechanism, and usually where human support is also included and there's some human oversight. Now, randomized control trials are essential, but so they'll tell us whether a digital intervention works for a pre-specified outcome under controlled conditions. But often what findings you see in research struggle to translate in clinical practice. Okay, so you may have strong effects in research, but you try and do it in the clinic and you don't get the same effects. And so to avoid this sort of failure at implementation, if you like, we also need to ask not just does it work, yes or no, in the RCT, that is important, but we also need to ask who does it work for, in what context, and through what mechanism. And this means thinking about implementation from the outset. And I think this is what Professor Chan was talking about in her talk as well. Don't wait until your trial is complete or until you've developed the intervention. You need to be thinking about that from the outset. And we need evidence not just of efficacy, but it's important to think about that ecosystem, because if you go and then put it into the clinic, you won't get the same effects, trust me. Well, usually you don't get the same effects. Okay, so I'm just going to focus in now on something a bit more specific called digital remote monitoring, but this is called all different things. It's a sort of ESM methodology, EMA, measurement-based care type idea, or a sort of digital phenotyping type idea. And digital remote monitoring is the repeated or continuous collection of health-relevant data from people in everyday life, usually using things like smartphones or wearable devices. And so, for example, just like a doctor might use a blood test to guide physical treatment, mental health providers can use these ongoing measures to track progress and adjust care plans in real time. And the key shift here is not just that we can collect more data, it's that we can observe patterns closer to where life actually happens. So in daily life, outside the clinic rooms, between appointments and over time. So that blank space that I was talking about. And I think this idea of digital remote monitoring is particularly suited to psychosis because it provides a more continuous thread of information, especially when care is fragmented across services. And it can reduce that burden of recall that, you know, how have you been? And it's really hard for me to accurately tell you how I've been feeling. And so the point here is to enrich the clinical picture. It's not to replace the clinical picture, it's to enrich it. And digital remote monitoring is one way I see us moving from my earlier image of this episodic model of care to one that's more connected up and one that's a more measurement-based care. And that really is the opportunity, okay, that digital and these digital tools, the phones and the watches and things that we have on us. The challenge is whether we can turn a rich multimodal digital system into information that's clinically meaningful. Okay, and there's still a big gap here to make this information usable by clinicians and by services, and also, most importantly, by patients themselves. So one reason I think passive monitoring, so this is sensor data, has become possible is that sensors have become really small. So excellent to the engineers in the room who've made them really small, because we now have got them in the phones and we can have them in our watches. And we carry these things around with us all the time. So this gives us an opportunity to have measurement in the flow of daily life. And these devices collect huge breadth and huge volume of data about all sorts of things, you know, sleep, your heart rate, your steps, your phone use, your speech, etc. And they really give us an opportunity to have granular insights into somebody's mental health. So the challenge with this is our ability, though, to transform this high frequency raw sensor data into interpretable markers of behaviour and emotion, and then situate those markers within a care pathway that support timely and proportionate clinical action. Okay, so that's the sort of different fields that we need to try and connect up. So what does the evidence tell us about passive sensing and wearable devices? This is a review that we conducted in our team on passive data for remote monitoring in psychosis. And we summarised data on over 200 studies and found that passive sensing is certainly an emerging field and a rapidly expanding field, but it's very fragmented. So accelerometers and smartphones were the really common device types that were used across study. And most people tend to be using these things to measure sleep and physical activity. So they were the most frequently derived features from sensors. And we also found that passive sensing field is heterogeneous in devices and sampling and feature extraction, reporting standards, the analysis methods people are using, and handling of missing data. Missing data is a huge issue in this space as well. So we made a series of recommendations from this review about how to report this in the literature so we can start having better comparisons. So it's important to report the device, the sensor, and the sampling details to allow for these comparisons. People weren't clarifying what was raw versus proprietary features that were being extracted. We need to define data quality checks and data and usable thresholds, because sometimes you might get hours of a readout, sometimes you might get a few minutes, because these really vary widely among studies. Not everyone reports missingness, and how that's handled and managed. It's really key, because missingness can sometimes be a clue in and of itself of somebody about to relapse or becoming unwell, but it may also just mean that the phone's broken. So this is something that's a challenge for us. And sometimes people use methods on very small samples, like people apply machine learning methods on like really tiny samples, which just creates more noise. And people need to make their code available so that we can reuse and have more transparency. So if you've ever have people worked with sensor data in the room? Yeah, okay, so it's still emerging, I know. If you've ever worked with sensor data, it's very messy. Digital data doesn't sort of arrive at this ground truth or clinical truth in and of itself. It arrives as fragments, okay? It's messy, it's often incomplete, it's device dependent. So the steps you get on a Samsung watch are different to the steps you get on an Apple watch, which can be different to the steps that you get off a Fitbit. It kind of looks like this. So I just took a snapshot of one of the buckets of our sensor data that comes in, and it looks like that. And I don't know, you go and interpret that. It's very challenging and very difficult. And so, you know, a reduction in step, and how do you interpret it? So a reduction in steps might indicate a relapse or that you're becoming more depressed, but it might also reflect it was bad weather that day and you didn't get outside. Or a change in routine, or you could have had a hospital admission, or maybe your phone broke. Okay, so it's really hard just because you're capturing steps one day and steps the other day. It's very hard without context to know what does that actually mean. Increased phone use could reflect distress or insomnia or avoidance, but it could also reflect work demands or just a greater period of activity online. So this sort of contextual information is really important. So passive sensing, although we talk about this, doesn't really in and of itself give us ground truth. So something sort of simple like step count isn't necessarily equivalent, okay, across devices. So passive sensing gives us behavioral traces. But those traces really need clinical and statistical and ethical and lived experience interpretation before they become meaningful. And this is the power of team science. Is this a term that's used here? Or interdisciplinary working. So you need many different, this needs engineers. We employ data engineers to help with processing these data and these pipelines to make them then statistically interpretable, and then the clinicians can make them clinically interpretable, as well as the patients who we also involve in that process. So we need these sort of transparent data pipelines to mitigate this black box problem that we talk about with algorithms. And ethically, we need to be able to show how this raw data becomes usable evidence, what assumptions we're making of that data, and what features are extracted along the way, and how these decisions shape the signals we eventually see. So in our team, this is the process that we work through. If you're thinking about wanting to use sensor data, this is a process that we work through to make things transparent. So when the sensor data arrives from phones or wearables or apps, they're not ready for research use or clinical use. So they'll come in these large volumes, and they come in very small files that you have to piece together. So it requires proper data engineering support. So we work with a data engineer to develop our engineering pipelines. And the first step they work through is processing. This means when they're sort of cleaning the files and removing duplicates and redacting sensitive information and organizing the data in a consistent structure. The second step is slicing. So this is where we define the sort of exact subset of data that's needed for a particular research question that somebody might have. Then we work through derivation. So this is where we turn the records into variables that researchers and clinicians can reason with. So this is where you might get your step count number or your heart rate value. And then we work with the clinical team who then, like I say, interpret those steps into something that may have clinical meaning or relevance. And for us, and we document this all along the way. And for us, this reduces that black box effect. So if we can't trace how an output was produced, we can't properly evaluate it, we can't reproduce it, and we can't govern it or use it responsibly in care pathways. And it also needs to be explainable. So I think ethically, we need to be able to say if an algorithm is working, we need to explain how it's working and how it's making its decisions. So if you're looking to work with sensor data, do detail a transparent pipeline. And it will build trust in your models, and it also builds trust in the clinicians and the patients if you can explain this. Okay, so I'm particularly interested in using digital data to predict psychosis relapse. So I'm working in the space of prediction. But prediction isn't just the endpoint, so that is a challenge in itself. But if we just generate a risk score, for example, or flag when an early warning sign might happen, we haven't actually yet delivered care. We've just identified a possible signal, but we haven't turned that yet into a therapeutic response. So to do that, we have to ask a much wider set of questions. And I'd encourage you to be thinking, not just developing your algorithm, but thinking about these wider sets of questions along the way. So if your model does identify elevated risk, over what period of the prediction window are you looking at? Are you predicting deterioration in the next few hours, in 7 days, in 28 days? What's going to be clinically useful? Who receives an alert? What are they expected to do? What happens if the patient disagrees with the alert or the signal? What happens if it gets flagged up outside of working hours? Who's responsible for an alert if it's missed? And I can guarantee that if you go into services or you've got your algorithm and then you want to deploy it in a clinical service, these are the questions that the clinicians and the patients will be asking. And so if you can be thinking about this beforehand, you're already going to be steps ahead of others. Because it has secondary implications for implementation. So if your system just identifies possible deterioration, but there's then no response pathway, it can increase anxiety for people. So it might, okay, I've detected a relapse, but now what do I do? It can create anxiety. And it can sort of shift burden sometime onto patients and families. So it's really important you think this through. And it's really important that you involve the stakeholders who are going to be affected by these digital tools from the outset. So don't wait until you've developed the digital tool, because you don't even know if your idea is a good one. It's exactly what Professor Chan was saying in her talk as well. Okay, so we include people with psychosis when we're thinking about the research question, or somebody might say, I'm having this problem, and that helps generate our research question, and we involve people all along the way. Also on our decision-making board, so we include people with lived experience in our grant applications. We include it in our analysis, actually, of when we're extracting features. We ask people with lived experience, is this feature even relevant for you? And so on. Okay, so when we're thinking about prediction, predictive accuracy definitely matters. So we definitely want to know if a model can identify risk with acceptable sensitivity and specificity. And we need to understand the false burden rate. Because sometimes if you're trying to develop an algorithm that isn't accurate and it keeps telling you you're having a relapse when you're not, you get sick of it and then you stop using the digital tool altogether. So it's really important to get this right. But like I say, there's all these other questions, and I continue them on the slide about safety and actionability and equity. Is this creating greater inequalities for people who don't have the digital or mental health literacy? So sometimes the thing that you're trying to create has these unintended consequences, and it's really important to think through that from the outset. So for me, the next phase of digital mental health is not another app or a clinician dashboard where we get these signals that come through, or an AI model, for example. It's really an ecosystem. And this is what I just really want to be a bit of a take-home message for my talk. And this is also reflected in the direction of policy and evaluation, certainly in the UK. So NICE, which is sort of what recommends whether people should use a treatment or not in the UK, also signals this broader shift. So they say that digital technologies that require clear clinical use cases, evidence generation, governance, and implementation pathways. So even policy is thinking about not just the digital tool you might build, but what is needed around that tool for deployment, so that we reduce this failure rate from research into practice that we tend to see in digital. And that brings me on to a role that's becoming increasingly important. And it might be called the digital navigator. Professor Chan, the digital buddy idea, I think, is a similar idea, and I think it's a great one, and it's a really important role. And the digital navigator is what sort of sits between the technology and the patient and the clinical team. And I think what we sort of tried to do before was expect the clinicians to also do the digital and have the digital literacy. And now I think we see that there's a really unique role that's needed to support this use of digital technology in clinical services. And so the digital navigators, or they're called lots of different things. This is a term that's commonly used, can really help ease some of the burden of the digital technology and the training and the digital literacy that's needed, and can help support patients, but actually also clinicians who can sometimes say they don't feel confident using technology themselves. So it can help bridge that gap. And I highlight here by a colleague, Dr. John Torres in the US, who's developed a really nice digital literacy program as well, that's really helped us in developing and shaping the digital literacy training that we think is really important alongside the technology. And so what do we know about the workforce readiness? This is where I say, if you are building your digital tool, think about how ready the workforce is that supports the patient. And our qualitative findings suggest that clinicians don't all start from the same position. They tend to fall across a spectrum. So I find that you sort of have the skeptics. So some people are skeptical, right? They sort of raise lots of concerns about ethics and privacy and, oh, this feels like surveillance, therapeutic value, and that it's going to affect the therapeutic alliance and devalue human care. Then there's a group that are sort of curious but unsure. I'm curious if you all think where you are as well in this sort of piece. So others are curious or unsure. They can see the potential of digital mental health, but they want really clear protocols. They want stronger evidence and some practical support and training with digital tools. And then I find you sort of find your champions. So they just are all for it and see a way of digital to enhance and extend care. And my point with this slide is that if the workforce isn't ready for digital disruption, even the most sophisticated tool is going to struggle to improve care. And if our ultimate goal is to improve care, we need to be thinking about this as well. So to understand a bit more what this means in practice, we did some qualitative interviews with healthcare professionals and also with service users, patients, clients. So we did qualitative interviews with nearly 60 mental health professionals working across UK services. And we asked them about this sort of multimodal digital phenotyping system that identifies signals of relapse becoming part of a digital care pathway, and how they feel about it. And clinicians said that they could see the potential value. They saw that it might support earlier identification of warning signs and sort of fill this blank issue that you see between appointments. But their support was conditional. So they wanted confidence that the data were accurate, it needed to be meaningful, and it needed to be clinically interpretable. And they raised concerns about privacy, about passive sensing, actually, more so than app reporting. Location, so they didn't like the idea that you can track people's location for obvious reasons. And they also worried that if it was used poorly, it was going to weaken rather than strengthen the therapeutic relationship. And they asked those very practical questions I put up earlier, like who's responsible for this? What happens if I miss an alert? What sort of legal responsibility do I then hold as the clinician? And then we asked the same questions to patients. So we spoke to 58 people with psychosis from the same centres. And patients also recognised clear benefits. They saw how detecting signals could support earlier intervention. But trust depended on accuracy as well. So they sort of recognised if you had too many false positives or too many false negatives in the signals, that was going to reduce their trust and they would probably disengage over time. So they especially wanted a human in the loop. So patients wanted to know, they weren't sort of averse to it, but they wanted to know that there was human oversight. So the concerns that were raised by participants is something that led to us forming this network. So this is a network that I convened called the International Collaboration for Harmonising Adverse Events. It's a long name. iCharts is the short name of it. And what we tried to do here was look at how we can improve how adverse events, because often when people run digital trials, they don't also report on adverse events. So this classically comes from the pharmacy medication effects, but we need to do this in psychological trials as well. We haven't always been very good at that, and we need to do it in digital trials. Are there negative effects from using these tools? So it's important you monitor this as well in your digital trials. And we found that digital tools are largely safe and we didn't see a major pattern of harm. But actually the evidence, not many people report this. So just because there's an absence of evidence of harm doesn't mean that it's necessarily evidence of safety, because we need to do better at reporting this. So it needs to be actively monitored. And we made a series of recommendations, which was define what an adverse... Wrap up. Okay, define what an adverse event is. And really, yeah, the point here is to think about monitoring these adverse effects of the studies beforehand. So I'm wrapping up. Yeah, I'm going to wrap up there and open up to questions, I think.
Yeah, thank you so much for your presentation. I think it is very inspiring and practical, so we don't aware of the time gone. Okay, any questions from the audience? Yes?
Thank you. Thank you. Thank you so much for the amazing talk. And I actually got two questions. The first one is you mentioned that the contextual information is very important to for us to interpret the data. So could you tell us a little bit more about how do you collect those contextual data and how do you combine with the data set? And the second question is because we know that people with psychosis, oftentimes given their prior experience, sometimes they have trust issue
Yeah.
on being collecting data about them, and what kind of challenges that you encounter during this process and how do you resolve them? Thank you.
Yeah, great questions. So the first question, we use multimodal forms of data, not just passive, to contextualize. So we have an app that we use that asks people to rate their symptoms or well, a range of experiences on a 1 to 7 scale. So what we can then do is cross-reference if, for example, I don't know, somebody didn't leave the house. So if the passive indicated reduction in behavior or a heart rate change, and the self-report says at the same sort of timestamp, I feel stressed right now, or I have another feeling, then it's just a way that we try and triangulate that measure into the person's self-report. So I do think at this stage, it's important to combine both the patient's subjective self-report of how they're feeling, rather than just collecting the passive data stream to help some of that contextualization. But there may be a way in the future of having both sort of passively only generated models and multimodal models. So we integrate multiple data sources to try and do that contextualization work. So that's the first thing. The second point about trust, I think that's the way we work with that. So it's not for everyone. Okay, so there are some people who will come into the trials or maybe don't consent to the trials because they have paranoia beliefs around surveillance and technology. So that doesn't work necessarily for the people. And we do see that in our trials, or we'll do see people who will stop using the tool because their paranoia increases, for sure. But this is in a small number of people, and it's a bit like anything. It's, not everything's for everyone. So where that happens, this is why we need to monitor the adverse events, right? So you can say in advance what the anticipated side effect of your technology might be. And that is definitely the case for people who have paranoia beliefs around technology. More broadly, though, the way we work around trust is having these explainable pipelines, like I was saying, so we can explain to people how the information's been generated and how it's been used. We also are working with lived experience partners. What's the term that's used here for patient and public involvement, or co-design? Co-design. Actually, because we co-design the research questions and the tool and how it works, and we tell patients that it's not just from us as the researchers, this is what the community have told us. That also helps build actually trust in what's being developed and who we are and what we're aiming to do.
Okay, thank you. And any questions? Sorry that the time is running short, so we can encounter one more questions, and then we can if you have further questions, you can discuss after the keynote sessions together with Professor Bushi.
Sure.
Hi, Professor. Thank you so much for your presentation. I think it's very practical, and I kind of label myself as curious but doubtful. Because you're working with patients with psychosis, and they present with varying symptoms. And I think the first question asks why you, because they have a lot of paranoia. My main concern is, when do you intervene? So do you intervene when patients are their lucid interval because of ethical issues? So when do we intervene with digital monitoring devices for the patient? And can you provide guidance on when we can intervene for this patient and which type of patients we can use these devices for?
Yeah, so the way we intervene is we've built, so the data that's generated by the tools is integrated with the electronic health record of the clinical service. And we've developed already an algorithm that in the research trials that will identify an early warning sign. So what happens is the clinician comes in and opens up the electronic health record and can organize their patient list. And we have like a traffic light system. So there's sort of, you can organize your caseload based on sort of red, amber, and green. So if you see patients have sort of flagged up a red alert of an early warning sign, that prompts the clinician to phone or contact the patient. So then have a conversation. Obviously, the patient knows that they're on the digital stream and this is being integrated into the care service, and it's been explained to them that if an early warning sign is flagged, that generates a prompt for the clinician to make contact. So that's how we manage it, by building it into the electronic health record, flagging up an early warning sign, and then either the digital navigator or the clinician contacts the person when they've seen the alert and has a conversation. Now, sometimes it may mean the person just needs sort of a light touch, supportive conversation. Sometimes it may mean there is a relapse happening and then you can get the care out to somebody. So, and we find that actually people along different levels of illness levels, it is appropriate for, so long as they've consented to signing up and using these tools. And people use them over a 12-month period. And the team are trained in how to respond to these alerts, and it triggers a relapse pathway within the clinical service. So we built it into the clinical service to manage. So it's not it's not a researcher tool, it's a clinician tool. Does that answer? Yeah.
Yes, this session is very inspiring. Remember, the three take-home message is very important. Technology helps us to detect the signal, but as a healthcare provider, we need to build up some system to interpret the signal and then detect the sign and symptom, especially those, I think 3 days before in Hong Kong, citizens know that that traumatous events, and then if we can early detection, we can help. And anyway, thank you very much once again for Professor Gu's inspiring and practical session.